Well, thank you very much for this invitation to be here. When I was contacted by the Hunter Wound Interest Group and through their association with Orma, New South Wales, to be asked to come back up to this area and to Maitland again, I did get a bit excited, and I have looked forward to coming, and I have very much enjoyed preparing the session for you. I look forward to chatting with some of you afterwards as well, and I want to thank the team for this really fascinating topic I was given, and it was, in short, biofilm-based wound care. So we're going to chat together for the next 50 minutes and look at this subject in a bit more detail. So again, I do express my sincere thanks and congratulations for what is happening here with this National Wound Awareness Week that's occurring next week. You know, this elephant in the room has to be acknowledged and it has to be promoted, doesn't it? Because I'm a little sick and tired of someone saying, "And what do you do?" And I say, "I care for people with wounds." And they say, "What do you mean, people with wounds?" And I thought, what have I been doing with my life for the last 20 years? Because my life and my day and everything is very full and busy, yet there still seems to be so many people unaware. It's like this hidden thing, isn't it, that people don't know. So we really do want to get that message out with this campaign, because wounds are one of the most common reasons why individuals of any age group will seek help from a healthcare professional. Did you know that? They suggested in the late 90s that there was over 70 million people with wounds around the world. And we know that the estimates here in Australia are of over 400,000 people with wounds that are failing or being delayed to heal. But I bet you bottom dollar, and I'm sure you agree, I reckon the number's bigger than that, don't you? Because every single day we are confronted by the challenges of a wound that is struggling, that has become complex. And in fact, what I want to start tonight's session in doing is identifying the fact that they are attached to a human, living, breathing, feeling individual. And I know that every single one of us is here in this room because of the fact that we want to do things differently for the people we care for. Can I get a amen? Amen. Amen. And that is very much in line with our Australian standards, that sort of line in the sand that we all try to develop our protocols and policies around, and earmark and reflect back and ask ourselves, am I working towards these standards? The Australian Wound Management Association has said that people with or likely of developing a wound, they deserve personalised care and management, and that is supported by current validated research. And so I guess that's a little bit about what these evenings are. That's about what this promotion and campaign is about, so that not only we learn more, but that we can share this message with others. And there is a real responsibility for us to get this right. Do you feel that sense of urgency with these people and the fact that we do need to do the right thing by them? So it pushes us to learn, to develop our skills and develop our knowledge. So here we are with this subject, biofilm-based wound care. So what we're going to do is look back on the subject of bacteria and infection, and then take a look at where we are now and look forwards. And I'm going to challenge you potentially. Some of you may never have heard of this before. Many of you may have heard of this over the last couple of years. But it is a real paradigm shift in the way we are going to think about people with open wounds now and in the future. We're going to look at the way that we have investigated people to try to gain a better understanding beyond their signs and symptoms of if there is a bacterial issue. And we're going to look at what some of the future exciting cutting-edge investigations are that are going to and are happening in our professional lifetime. And then we're going to look at this thing called biofilm-based wound care and ask ourselves, can we do that? Can we deliver it? And what are we doing in our practice towards this? So let's set the scene. We have a wound, we break the integrity of our skin. Well, we hope that it would heal. Have you had a wound and it healed? Have you known people that had a wound and it healed? Of course. That's what the body is programmed to do. From the minute the injury occurs, it wants to restore integrity and bring everything back to what it was. But we know that a lot of our care is in those wounds that occurred that all of a sudden start to lose their thrust. They become a bit stagnant or stalled. One other word used by Peter Bowden was stunned. Has anyone got someone that they're caring for at the moment that's got a stunned, stalled or stagnant wound? Yeah? That's what we're talking about. And yes, of course, by the time we get to that point, by the time we get there, whether it's a pressure injury, a neuropathic diabetic plus or minus ischemic foot ulcer, whether it's a vascular ulcer of a variety of etiologies, or whether it's an atypical wound, yeah, they're different and they need different interventions and treatments, etc. And they're on different individuals that demand that we look to them to understand it. But what has become quite dramatically clear in recent years is that there is a universal barrier within these wounds that is stopping them from healing. Can anyone tell me what they think it is? Well, yes, well done. And in fact, it's this persistent inflammation. We're going to look at whether it's the chicken or the egg. Is it the biofilm or is it the inflammation? Or is it both? But this is universal, whether it's pressure injury or venous leg ulcer. Once it has become stalled and stunned, if we tested the fluids and what is happening in the cells within that wound bed, it is different. It's not the inflammation that we have at the beginning of an acute wound injury in those first few days, which is essential for wound healing. It is persistent pathological inflammation, out of control, out of balance, and thus no other part of wound healing can move forward. And we see a failure to heal. Again, the literature describes this scenario, and just think of these people living with those wounds. And they describe the environment of that wound as vicious and hostile. Doesn't sound that conducive to healing to me, does it? Vicious and hostile. And as we look at it on the macro, not what's really happening at the micro, but when we look at these individuals, they present to us with clinical signs and symptoms of non-viable tissue, increasing levels of exudate, signs and symptoms of inflammation and or infection, and they will often describe pain. Do you agree? That whole progressive familiar characteristic of what you see, again, whether pressure injury, venous ulcer or atypical, they begin to take on a look and a sense and a feel, don't they? And we begin to start, I guess, having to face these very common challenges. To address these local barriers to healing, back in 2001, Gary Sebald and another guy called Falanga, at about the same time, both wrote a paper. But then within a couple of years, Schultz et al. And a whole heap of other international clinicians got together and formulated a term called wound bed preparation. I bet you've heard it, I bet you practice it. And this concept was saying, yes, we need to look after the individual, but we also need to address these barriers within the wound bed. And we're going to obviously talk about one of those barriers tonight. And I do want to reiterate that wound bed preparation is done in the context of knowing your diagnosis and treating it, understanding those factors or comorbidities and treating what we can, and addressing what is important to the person. That is wound bed prep, not just the wound. So with that healthy respect of the term, I would like to highlight, and with much pride, present to you an article that was published in late 2012, an international article looking at wound bed prep in a reflective way. This was proposed over a decade ago. Is it still relevant to clinical practice today? Is it a term we should be using? Has there been new or evolving knowledge in the last 10 years that might enhance the way we do wound bed prep? Or does it change the way we do wound bed prep? And guess who's on it? Guess who wrote it? A couple of Aussies. What do we hear? Aussie, Aussie, Aussie. Oi, oi, oi. Terry Swanson, the first nurse practitioner in Australia for wound management, and Carolyn Carville, Professor Carolyn Carville, who we all wish that we could just be reborn and become Carolyn. There's someone that we go to as our expert. Incredible. And you can find more information on this fantastic website, the International Wound Infection Institute. In fact, Terry Swanson, as a nurse practitioner, is currently the international chair of this. It's very exciting, the international village that we're all a part of now, and that we are playing very active roles, or they are playing very active roles on our behalf. So you were very, very clever before when you said maybe biofilm is a barrier, because the chronic or the pathological inflammation and the biofilm go backwards and forwards. And in fact, we know that that will increase the chance of a failure to heal. Let's look at this quote together. Again, round about 2008, when we began to see a lot of published data on the topic that we're going to talk about tonight. And this group said, we propose that the lack of proper wound healing is at least in part caused by an ineffective eradication of infecting, opportunistic, not organisations, but organisms. And that a mature biofilm is proposed to be a primary barrier to wound healing in one of those stalled or stunned or stagnant wounds. Extraordinary. Persistent inflammation. So if we look back and think about how we've considered inflammation and particular infection in the past, it would come as no surprise that a wound infection we've always understood was based on the virulence or they thought it was the numbers of organisms, didn't they? The sheer numbers, or whether it was a particularly virulent organism, and whether the host was able to put up a good, healthy immune response. Do you remember that sort of equation we all used to look at? You know, the number of organisms, the virulence of the organism, and the host response. We know that the overall concept of wound infection is negatively impacted by the health of the person and the health of the region where that wound is and the wound itself. And it is negatively or positively influenced by how we manage it, the therapy that is introduced. I don't think anyone here would disagree with that. What we know, though, in infection is once it becomes out of balance and those numbers do begin to increase exponentially, they're the ones taking the oxygen that's squeezing its way down through that edema and desperately trying to get to the wound bed. They're the ones that begin to take the nutrients. They become the dominant cell in that wound bed. And because of lack of nutrient and oxygenation, we see poor wound healing. Ridiculous, shall we call, pathetic granulation, or a failure to lay down collagen. And so this concept of a link between poor healing and infection, we've kind of known that, haven't we? If we have increasing numbers of organisms, we are going to, in a healthy, normal immune response, we're going to have a raging movement of really wild and crazy white cells oozing their way out of the bloodstream and making their way to that wound. And when they get there, well, they really go to town, don't they? They can create this reactive oxygen species, which effectively can sort of nuke something. It helps them phagocytose organisms and foreign materials. And another key thing that white cells or polymorphonucleocytes do is they stimulate little chemicals that maintain an inflamed response so that the blood vessels stay dilated, so that there's lots of blood getting there, lots of oxygen, lots of white cells. So pro-inflammatory cytokines, they're just little messages telling the body what to do. And through this process, they also create a thing called a matrix metalloproteinase, something that can break down protein, the basis of what a human body is. Yeah? So these white cells, at the same time as trying to protect and destroy bacteria, in a way, if they're allowed to get out of hand, they can themselves cause trauma and damage, just as the bacteria themselves can. Everything that just came out of my mouth about what is exuded out of the white cells, who are our Arnold Schwarzenegger soldiers, the baddies, or it's a different movie, but the Darth Vaders, I wish I could remember the baddie in the other one, but the baddies are also triggering releases of these chemicals. They're also releasing endotoxins, which are incredibly toxic to normal healthy tissue. And in fact, both, if out of balance, can totally destroy growth factors, which are just chemical messages oozing somewhere to tell something, grow this blood vessel now, lay that collagen now. It's just a message. And it's destroying the receptors on the cells that are meant to take hold of that message. In a nutshell, it screws up wound healing. Do we hear an amen to that? Yeah. This is David Leeper, who for a very long time has been involved in this topic of wound infection, based in the UK. And he said infection is the main cause of delayed healing in primary closed wounds, so surgical or post-trauma, burns, and chronic skin ulceration. We know that it causes pain. We know that it changes people's lives. We know that the costs of care through length of stay, complication, further interventions, more antibiotics, longer care plan time frames, more products used. It's like tipping money down a bottomless pit if we're caring for an uncontrolled infection. So do you all agree that this is a topic that this group suggested we should talk about? Do you think they picked an okay topic? Yeah. Very relevant topic, isn't it? So if we look at how we have tried to work out, is that wound infected? Is this wound infected? Or is that just inflammation? We're going to look at that right now. And these are the cardinal signs that we were drummed into us as healthcare professionals, wasn't it? It needs to be red, hot, swollen, painful, pus is good, and it's probably malodorous, right? Now, I can tell you, and I bet you can agree with me, I will go and look at different people's wound assessment charts around the place, and they are the characteristics on that wound assessment chart that those clinicians are looking for to work out if it's infected or if it's a bit buggy or whether it's out of balance. Would you agree that that's where we've come from? Yes. Okay. 20 years ago in 1994, now I'm old enough to remember it. Anyone else around in 1994? Yes. And I read this paper, and it was Keith Cutting and Keith Harding from the UK, and they said, you know what? We think that difficult or non-healing wounds might act a different way. And they began to describe characteristics like friable tissue that bleeds really easy when you just look at it sideways, or a rapid deterioration, or a stalling in a wound that was healing before. Certainly pain came up. And I read that paper. Did anyone else read that paper? Or did you all have a life in 1994? Yeah. I read that paper and it was like a light bulb came on in my head and I went, oh, that's probably what was wrong with Bob. It began to make a lot of sense. And they proposed over the next couple of years this term called critical colonisation. Somewhere between colonisation and this airy-fairy infection thing, yeah? Something in between. Gardner in 2001 also began looking at different wounds and did a validation study. And this is just an example of that fire engine, bright red tissue. Not all red tissue is healthy tissue that just bleeds exponentially, and this has got worse and it's now painful and the exudate has increased. But certainly Gardner's work in 2001, they looked at the work that had been proposed and they said, this is right, we agree. And in fact, pain and wound deterioration or wound breakdown were very highly identified as being quite specific in telling us that something was happening in this wound, other than the hot, red, all that stuff, pus, etc. They went on, multiple other authors have suggested that wound healing can be delayed in a wound in the absence of those classic signs and symptoms that seem to be on all the wound assessment charts. That they can be subtle. Another word they've used is covert, and that it can fail to heal or progress and deteriorate. So as we go on this journey from 20 years ago to the early 2000s, for the first time we had a working diagnosis of what a wound infection was, again proposed by a couple of leading clinicians from the UK. And it said an infection is a replication of microorganisms where you see a subsequent host response, and it will lead to an inhibited or delayed wound healing, right? So we began to make that connection that that wound was going to hang around. A couple of years later, again, predominantly the European leaders were driving this subject internationally. And they got together and proposed several position documents. Position documents and consensus statements are about subjects where at the time there isn't much evidence as such to base our hat on, and they bring these people together to discuss. And they, for the first time, said, we're going to say it right up front that acute wounds and wounds that are failing to heal are and potentially can look and act differently when they're infected. And they just went like that, and that was that. So what has happened in the last decade? In 2008, I feel one of the most pivotal documents that was proposed, and again, an international consensus now, not just the European group. And there was dear little Carolyn again, part of this group, out there waving the Aussie flag. And together, they took all the work that had been done previously, collated it, reviewed it, looked at what had been published since, and they proposed this document that is freely available to you from woundsinternational.com. Wounds International now is the place to go for many of the World Union Wound Healing Society documents, where lots of different societies, that village comes together. And they propose this differentiation between a trauma or a surgical wound and a wound that was failing to heal. And here, it's not for you to read now unless you're Superman and you've got incredible vision, but the green arrow is saying this is what the local infection of a surgical traumatic wound might look like, which tends to be more those classic signs, yeah? And this is what spreading infection will be. And the reason why they've differentiated local and spreading is that local is obviously where we're using our antiseptic dressings, and we're using them here, but we're also using antibiotics here. Yeah, is that okay? At the moment, here in Australia. And then here, this was what systemic infection would look like for either group. And this is what a local infection would look like for that more challenging long-term wound and spreading infection. If you haven't read this document, you haven't seen that table, you haven't lived. It's true. And we have Smith and Nephew to be very grateful for, because you know how the different companies get incredibly interested in several different facets of what we do, and they have been very actively involved in wound infection for over a decade now. And as other companies have been focused on lots of other areas as well, they were the ones that were able to help bring people together. And it clearly says in all of the documents, Smith and Nephew have nothing to do with the content of what's in this document, but we thank them for bringing the people together so they could discuss. And within that document, we began to see this language of classifying different types of wounds. And we can see here what we're familiar with, contamination, colonisation. And here is what 20 years ago they called critical colonisation. Today, we call it local infection. Subtle infection, covert infection, local infection. Something is definitely happening, but it hasn't yet spread and it's not systemic. How's that? Everyone comfortable with that language? Right, so you ready? Hold on to your hat. This is a biofilm. I'm going to describe it to you in a moment, share more information about it, but I want you right up front to make this connection between this hypothesis or theory that has been proposed by some of our world leaders back in 2010, and they're postulating and now saying, is local infection biofilm infection? All right, I would like you to remember that diagram, remember that language, and now I'm going to briefly describe to you what we're going to talk about over the next couple of minutes. Within an open wound, we have the risk of contamination or exposure to bacteria and organisms, don't we? Do you all agree? That's what our skin is there for in the first place. So if we remove the skin, well, it's going to be exposed by a manner of different ways. There they are. They're happy, they're swimming, some are doing backstroke, some are doing freestyle. They're just oozing their way through that fluid on the surface of the wound, and then they land. It could have been an accident, or they might have been attracted, who knows? We haven't yet chatted to them about that. And they land on the surface, and they go, that's all right. That feels all right. Yeah, I'm going to burrow down a little bit here. And do you know what the wretched things do? They drop their tails like a lizard. So instead of having a flagella anymore so that they can swim, they go, oh, hang the tail, and they let that go, and they start to adhere to that surface of the wound, yeah? We kind of called that colonisation, and I can remember in early days I used to say, oh yeah, they just got together and they're making houses and they're having a few babies. I really dumbed it down. Now I am as scared as hell of colonisation, because without a good immune response, what do you reckon happens? They shout out to their friends. They gave it a really lovely name. They called it quorum sensing, and they said, hello. It's like Pink Floyd. Is there anybody out there? And they say, come over, come over. And they do. And they come over, and there's no prejudice. There's no racial, oh, you're a staph, you're a strep, you're a pseudomonas. Oh, no, come in. The water's fine. Come together. Come together. Oh, over me. And that's what they do. And as they begin to come and they begin to gather, they start to make this thing called an extrapolymeric substance, an EPS. It's just armour. It encoats them. They're not just sitting there as I used to imagine in the last couple of decades. No, they're sitting there, and over time they're building three-dimensional entities, which some literature has described as sort of more alien-like. Over time, they can create communication channels and irrigation channels, and they begin to grow up, and the organisms inside go to sleep, and they're coated with this armour, And then one day they split open and they spill their guts. And some of those organisms, all the different ones that they gathered into the fold, some of them get spilt out and they go off to another part of the wound, and what do you think they do? They do. And the wretched things grow their tails back so that they can swim, right? Now that is an incredibly simplistic way of looking at something that we hardly understand. Something changes when a bacteria turns from planktonic to sessile, more silent and stationary and attached. Something definitely happens, and in fact, they now suggest that it's 80% of the human being's reasons for any kind of infection. It's because a biofilm has formed. Otitis media, cardiac valve issues, cystitis. It's organisms on the surface of something that have attached themselves and then coated themselves. Little buggers. For the first time in 2001, Davis et al., and let me say, it was Keith Harding, everyone, who was part of this group from Wales, that got together with the Faculty of Dentistry and worked out, geez, there could be biofilms like there are on your teeth at the end of the day, that stuff that you can feel, just those bacteria attached to your teeth, that could be on the surface of the wound, just like it can be on the surface of any part of a human body. And Woolcott, who we're going to become a little bit familiar with, because he has to be the godfather of this subject, suggested that the difference between a planktonic bacteria that we can gather up with a wound swab and one that has adhered itself to the surface and put an armour over the top, it's like a butterfly and its thing that it came out of, which is a... Thanks. The contrast between the two is exactly the same. Within that biofilm I've described, there is going to be all kinds of different organisms, and not just different species, but anaerobes and aerobes living synergistically together. While the aerobe gobbles up any oxygen, the anaerobe goes, I'm happy. Wounds are an ideal environment for the formation of biofilm because of their susceptibility to contamination and the available substrate or surface that, or substrate, the fluid and the nutrients, etc., and the surface for a biofilm to attach. We now know that this is a real issue. It was first seen on electron microscopes in the 2008. They published about it, clearly demonstrating that wounds that were failing to heal had a much higher incidence of biofilm than those that weren't. Why do you think someone gets a biofilm and someone else doesn't? It's the health of the person, the health of the region, and the health of the wound. And if they can't get oxygen, food, and nutrients and white cells down there, well then I'm sorry, but the bacteria are going to win. Their success I've already described. They put things to sleep. They allow things to attach. They really knock the white blood cells around. Those polymorphonucleocytes are going nuts because there's something on that wound. They know it's there, they know it shouldn't be there, but they can't seem to do anything about it. Can you imagine their frustration? Because they can't seem to get through that armour. It's also suggested that these guys, Woolcott, suggested it's a hijacking. They literally stimulate and taunt those polymorphonucleocytes and tease them into just a frenzy. They've also described a biofilm as a parasite, that they can not only be on the surface of the wound, but down in the tissue and often around the basement of a capillary, where when the capillary is inflamed and it's dilated, you're going to see movement of fluid out, aren't you? That sort of movement that we see in inflammation. And that fluid is full of oxygen and nutrients, and there's the biofilm just saying, thanks. They bait. Remember I said that they decide to open up and spill their guts every so often? They've suggested that that can happen as frequently as daily. And they also suggested that up to 30% of some of the organisms can be spread that way. It's amazing what a challenge this should be. So do you see a wound that waxes and wanes? Gets better, gets worse. Do you see a wound that has antibiotics, but unfortunately after they're finished, it just rebounds? Do you see a wound that you're getting everything right, the compression, the dressings, the nutrition, everything, but you just can't seem to get that wound to heal? Or you've got a non-healing wound that gets an acute wound beside it, and the acute wound heals and the non-healing wound just sits there. Alarm bells should be ringing for us. Alarm bells, because within that wound is a formidable foe. And we have dumbed down this subject for just 1 or 2 years too long. Don't you agree? In here, as knowledge begins to expand, we begin to realise that we can start to lose the battle. Have you ever felt you were losing the battle with something? That you were trying to get all the ducks in a row? So I'm going to ask you an honest question now. If a healthcare professional chooses to just stay with the knowledge they had in the past, it's comfortable, it's relaxed, that's what's on the wound assessment tool, and if they decide to just look at classic symptoms, is there pus? Is there cellulitis? Can you tell me, where does that leave the person in their wound? Anyone just want to... Where are they? Not healing. Up a creek without a paddle, aren't they? Now, if we practiced that way in the past, we did that because that was knowledge then. That was what we understood then. But we understand differently now. It's been a growing international momentum for now 20 years, and the last 10 years it's been defined and written down, and for the last few years there has been a frenzy of new information happening around the world. Could it have anything to do with these wounds that just won't go? Could it be one of the causes, do you think? Could it be a barrier? Could it be an area that we need to promote, increase our knowledge, and use those experts around us? And some of those, and I guess I posed a question to you, didn't I? Maybe I should let you answer. What do you think? Their answers are just too brilliant, Margot, and they would like to share them with you later. So if, with your permission, I'm going to leave that question with you, and let's look at investigations. If we now understand that there are different clinical signs and symptoms of a acute trauma or a surgical wound versus a wound that isn't healing, and they may look and act differently when they've got bacteria in them, what are the tests that we do to give us even more information? What are the investigations? You tell me. That's right. We want to find out what's in there, don't we? We want to know what it is so that we can look at the sensitivity so that we can then treat it. So we do an investigation when the results of that investigation will direct our local care. And how have we done it in the past? That's not very good English. We do it how Robert Koch suggested. A microbiologist from Germany, see how long ago he lived? And he came up with this thing that he won a Nobel Prize for, that he could take something and put it on an agar plate and put it in an environment where it would grow. And then he could identify different species and from that work out sensitivities, etc. Quite brilliant, hey, for that long ago. This is often how we do it, isn't it? This is how we collect that wound fluid from the surface of the wound and send it off to be cultured so that we can identify what it is and treat. And in fact, that same document that I told you about before from 2008, it's got a beautiful page there where it says, these are the tests we should do. This is when you should be taking a wound swab. This is how you could be taking a wound swab. That's quite nice, isn't it? It's all in there. And in this document from 2008, they said at this point in time, sampling techniques have not been validated as to one better than the other. But guess what? Aussie, 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 oi, oi, oi. Donna Angel and her group from Perth did a validation study which they only just published in 2011, and they looked at the zigzag method and they compared it with the Levine method, gentle pressure, gentle rotation over a 1 centimetre area of significant clinical significance in that wound bed. And they found that significantly more organisms were found with a Levine method than with the Z-plasty. Wasn't she a clever girl? And other people now internationally refer to the work that she did. So yeah, we do know now that there's a great way to take a swab. We can take fluid from the wound bed, an aspirate. We can take scrapings during debridement processes and send off tissue to be cultured. And you know that we can put off clippings and skin and look at different samples, of course. But a biopsy, a punch biopsy, goes down deep into the tissue and takes a core lump of that, and that can also be sent off for culture. Isn't that fabulous? I knew you'd be excited. So that's how we've done it for 100 years, and we could continue doing it for the next 100 if we so choose. But oh no, some very clever man in a white coat or woman worked out that you could check out molecularly the DNA. Now let me just share with you the difference between molecular, where they identify the DNA, and culture, where they ask it to grow on that plate. Look what they found in 168 wounds, a retrospective study looking at a range of different wound types with the number of different organisms in the molecular was 338, and the ones identified in culture were 17. Now, what does that tell you? We don't have to be rocket scientists to work that out. What's it telling you? Molecular's better. And what we know is that culture will still tell us something, doesn't it? It still picks up some of those planktonic organisms, still gives us an idea, but it's not telling us the big picture. And look what they found. Molecular, have you seen all of those before? Some of them we have, yeah? They found up to 33 different organisms, and look at this one here. With culture, staph and Seriacia and then the Pseudomonas, etc., up to 3. So one person had up to 33 organisms, one had up to 3 organisms. Isn't that amazing? The same person, the same wound, just tested or investigated a different way. Now, who is just thinking they're just off their planet with excitement? Because what about this one? 51 chronic wounds. Again, they identified different numbers of organisms in the same samples. And that historically it was missing up to 60% of just aerobic organisms, not the anaerobes that are hard to grow or the fungus that were hard to grow. And in fact, they suggested that when we culture, it is the best we can do at this point in time, but it's not giving us the whole picture. And some of the molecular tests, I just want to share with you that I keep reading them, I keep trying to understand them, and I don't get them. I don't get it. Someone else can be brilliant at that, but there are different ways that they get little DNA footprints, and it can tell them point of care, at the time, exactly what it is, Within a few days, they can identify the 33 different organisms that are in that wound. And finally, they can do that, which I have no idea what that does. As we look at molecular methods, I just want us to be excited, to keep our eyes open, because this is happening now. You can get a PCR done in Australia now. I can't get it done for my wounds. I don't know if anyone else can, because the guys that I am working with are saying it's too costly right now. But they began to tell me about other kinds of DNA tests that would sometimes, he described one that cost nearly $1 million to do, 20 years ago or 10 years ago, and today they're doing it for 150 or 200. So this is coming our way. Yes, people need to know how they do the test, and it is costly, etc. But it will come. We need to keep our eyes open. And right here in Australia, there is our wound management, the CRC up at QUT, and the collaboration throughout all of Australia and the Australian Wound Management Association. And two of their key objectives in one of their projects is to look at point of care, at bedside, things like a dipstick. Who'd like a dipstick? Just dip that in the wound fluid. Don't even have to take a biopsy, don't have to take tissue, just dip it in and let it tell us what's happening. Quite extraordinary. And they're specifically looking at biofilms. Our Australian researchers, and so are researchers around the world. Edwards Jones, a clinical professor from the UK in microbiology, she said that this kind of methodology tells us why some wounds don't heal that really just should have. Have you ever cared for someone that jolly well their wound should have healed? You had all their ducks in a row. And so let's accept that we can't maybe do it right now, but look at what they're saying. They think that molecular testing will become the preferred way that you and I will investigate and understand what's going in the wound. And that it has the potential to revolutionise treatment. There are some exciting times ahead, isn't it? We're fever-pitched and can't wait. And I just hope that we haven't retired or we're dead and buried by the time we have the opportunity to be involved. Because biofilm-based wound care relies on knowing what that organism is, doesn't it? Yeah? And I want to stay right up front that the people that put forward this term internationally was Randy Walcott and his group of pharmacists and microbiologists and from this centre in America. And they truly do a thing called biofilm-based wound care. We're going to look at what they do and we're going to look at what we can do. Biofilm-based wound care is know what you're looking after, look after the diagnosis and manage the person. Okay, that's gold standard wound management, isn't it? But they say biofilm-based wound management is getting in there and debriding it every single time you see it, changing the surface of that wound. And because they can know with their molecular testing exactly the 33 bugs that are in Barry's wound and exactly the 42 that are in Harry's wound, they begin to formulate local approaches that try to stop the biofilm from attaching. They give local and systemic antibiotic therapy, and they use antimicrobial dressings like we have access to. So this is what true biofilm-based wound care is, and I hope one day that we can do that here. They know, though, that debridement is so important because it ruins that armour of the organism. It makes it vulnerable, it makes it mature again, it switches on all the organisms, and if you then are giving it antibiotics, those antibiotics will be effective. The really great thing is that it works for several days before the biofilm starts to lay itself down. Let's look at the time frames. An organism can attach in minutes, a microcolony in a couple of hours, an armour in 6 to 8, and mature and spitting out and seeding within a couple of days. How's that for productivity? Anti-biofilm approaches using different research knowledge is looking at how can we turn off the chatting mechanism of the organism in the wound, okay? Antiquorum sensing. And look at some of the things they're looking at. Fascinating. How do we stop the biofilm from attaching to the surface, and how do we stop the armour from forming? This is the level of research that's going on around the world. And when we look at this particular study that looked at the different forms of biofilm-based wound care treatment, they looked retrospectively at 1,300, they had culture as the control, and then they had molecular testing being treated with systemic antibiotics like you and I would give today. Molecular, but being treated with an anti-biofilm product to try and smack it around. And they were custom designing individualised antibiotics for the 33 organisms that were in there, and they're placing it on the wound in a gel. I know, hold on to your hat. Now, when you look at the results, 48% healing rate, remember retrospectively they were auditing and looking, 48% on care with culture, yeah? So let's not just go boo-hoo, culture sucks, you know, that's not the case. But look what happens when we start custom designing, and look here, that approach using anti-biofilm, custom designed antibiotics, 90%. He said it has changed his world, and it has changed the world of the patients that he cares for. And the median time to healing was 177 days, 77 days, and 28 days. Who's excited? So, patient-specific treatment options is what it's about. Internationally now, if you lived in South Africa, you can buy a product that is an anti-biofilm product. Randall Woolcott is suggesting that if we really get that fluid up and away, then maybe we starve the biofilm. Isn't that interesting? And we've got capillary action dressings here, and we've got negative pressure here, and all of those things. In a nutshell, what they're saying internationally is, in people's opinion now, biofilm, and recognising that this is a reality, has already changed wound care. So how does that apply to us today? Okay? How it applies to us today is don't let the bacteria get there in the first place. I'm going to leave you ponder about that. Because we just say, oh, you know, oh, I'm not even going to open that can of worms. What are we doing to stop contamination? What are we doing to build up the health of the individual? And are we following those now confirmed principles of wound bed preparation? Because this emerging science, we know a little bit, there's more to know. But if you've treated every other factor, internationally they're now suggesting just treat it as if a biofilm exists. Yeah? So what can we do? You can send them to an expert that can do the debridement. Yeah? Or we can drive more training and access to these services for the everyday clinician. We need to get sharp debridement out there as an important tool. It is invaluable, and it is pivotal for breaking that biofilm and shaking it up. We can use ultrasonic debridement, and again, some of your local experts have got that in the region. And this is an example of one therapy. One therapy. We have Versajet as a hydrosurgical technique, and Linda, who's going to be your next presenter, is the most experienced person I know in using that form of debridement at the bedside. Extraordinary. Removal of wound debris and even granulation tissue is a way to address this formidable foe. We should be using our antiseptic dressings. We have silver. Silver is not the same, is not the same, is not the same. They can be same, but different, can't they? And you have got some companies here for you tonight to have a chat to about, and their level of evidence. But there was a negative study that occurred in 2009 called the Vulcan, and they suggested that really use of antiseptic dressings didn't make a difference. The design question was flawed and the study was flawed, and there's been international outcry. So out of that have come these recommendations. When we're using antiseptic dressings, do a 2-week challenge. If it's improved but there's still clinical signs, go for another 2 weeks. If it's improved and there's no more signs you're worried about, discontinue it. Or if there's no improvement, maybe discontinue, consider using a different type, maybe systemic antibiotics, and re-evaluate the person again. That is a pretty good roadmap, isn't it? And thus that then enables us to look at other products as well, silvers and all of our different types of antiseptic products, all of them with varying levels of evidence for biofilm management. And in coming with that comes the treatment of the edema and the nutrition and the getting rid of the fluid. It's all important. We need to know them, and you need to tap into these companies that have committed to you tonight, into 3M and Rye Pharmaceuticals and Smith & Nephew. Biofilm-based wound care. 2010, this is what they said. If you have a non-healing wound and you suspect a biofilm, then debride, 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 and vigorous cleansing. Prevent recontamination, suppress the biofilm reformation by using our antiseptic dressings, and continually reassess. Pretty straightforward, isn't it? And out of that thing, the only thing we don't have is those custom designed antibiotics. So take the concepts of biofilm-based wound care and grow with it, move with it. Look at those wounds that aren't going. Work together as a team in getting the outcomes that you know. So I'm going to close our session now to say that there are known knowns, the things we know we know. There are the things we know that we don't know. There are the things that we know that we actually don't know that we don't know them. And so that when we do the best we can and we pull all of this information together and we say, well, that's basically biofilm-based wound care, well, then that's really only the known knowns and the known unknowns. So every year we're going to discover far more things about the unknown unknowns. And I'm ready. Are you? Our journey continues. Join us in Brisbane, in the Gold Coast, in May for our national conference. And I encourage you to get behind this national campaign and make a real difference out there. Thank you.
Well done. Isn't she just fantastic? And so exciting, so easy to learn from. So thank you, Wendy. But I'm sure there must be questions for Wendy from our audience. Yeah?
How are we testing the molecular stuff, Wendy?
Yeah. Again, I have made inquiries here in Australia. I don't know of anyone of our colleagues that are using molecular. Did you have any success, Margot, locally? At the moment, they're really saying it's cost restrictive and that they don't have the skilled technicians to do the test, but they indicated that this is coming. Hold on to our hats and it will be the way of the future.
So what about in the US?
Oh, how do they do it? They use those 3 tests, the PCR, which is they have a specific thing that they put in it. And
is it like a dipstick? Is that?
Oh, sorry. Randy's work is all done on tissue. Yeah. There's work coming out of Japan that's done on fluid, and it looks like the CRC in Queensland are doing their work on fluid.
So it's in the US, are they doing incisional biopsies or punch biopsies?
Thanks. They're doing predominantly punch if it's a ulceration, but they're very proactive with sharp debridement as well. So they may even take just samples of tissue that they took, which we can do for culture here as well, and it's still incredibly insightful.